morning, everyone. Now we are talking the musculoskeletal system, and we are going to cover some pathology pictures regarding benign and tumorous lesions that can happen in bone and skeletal system, including benign and malignant tumors. First of all, here you can see this is a part of the femur bone. This is here inside this bone. This is a metallic prosthesis that was inserted in the bone due to fracture, severe fracture in this patient. Now, fractures usually can be traumatic due to trauma, or can sometimes be pathological fractures. But pathological fractures are called pathological because they are happen due to weakness in that bone. This weakness may be caused by infection to the bone, like in this case, and bone infection we call it osteomyelitis, or it can be due to lesion in that bone. We are going to cover some lesions of the bone, and tumors, benign and malignant tumors. So any lesion in the bone can cause weakness in that bone, and that may lead to fracture. And if the fracture is severe, sometimes we need to put metallic prosthesis inside the bone to help the bone for remodeling and healing in that area of fracture. Now we have in osteomyelitis, we have two types of infection in general in our body. It's either acute or chronic, okay? So this is a case of chronic osteomyelitis, and in chronic osteomyelitis, it's one of the conditions that are really sometimes hard to diagnose clinically, because they stand for long duration and with no specific symptoms. The patient may come with fever of unknown origin, or just fevers that comes and goes, and there's no localizing symptoms, and we go and we do a lot of clinical tests and laboratory tests, but we don't think of the bone usually unless there is something that tells us that there is something wrong in the bone, like local pain, or as in this condition, maybe fracture. Now, in chronic osteomyelitis, we have at the area of infection, the bone become necrotic, and we have fibrosis, and we have chronic inflammatory cells that, like we are going to see under the microscope in a while. And this necrotic dead area, we call it sequestrum, and that's the old dead bone. And we have a new bone formation that's going to heal and to remodel and to stabilize the site of fracture and infection, and we call it involucrum. So involucrum, it contains new remodeled bone. It's a little bit immature, and it's irregular, the bone trabeculae in it, and woven bone, and it's not as healthy and as organized as the mature normal bone in the skeletal system in general. Under the microscope, how do we see chronic infection? Now, chronic infection in the bone, it's like any chronic infection in any other tissue. We have chronic inflammatory cells, like you see here. It's a group of T cells, B cells, lymphocytes, and we have some macrophages sometimes. And in addition, in long duration, we have the formation of fibrous tissue, and we don't see fibrous tissue in acute inflammatory process. So the presence of fibrosis in this case tells us that this infection has been there for a long duration. Chronic osteomyelitis, it's difficult to treat, and sometimes it needs admission and needs close follow-up to make sure that it has been treated effectively. Now, this is an example. This is a microscopic picture for the other part of inflammation, the acute inflammation. Now, in acute inflammation, what types of cells we see? Neutrophils, of course. So here you can appreciate a lot of polymorphous neutrophils. And at the edge of the picture here to the left, this is a necrotic bone, dead bone. And this dead bone is being eaten by this cell at the edge What we call this multinucleated cell? The giant cell, we call them osteoclasts. Okay, so in the bone we have osteoclasts that destructing the bone trabeculae, and we have osteoblasts that making and depositing osteoids and osteocytes, like you have taken in histology. The osteocytes usually stay inside the bone trabeculae. Outside at the edges we have osteoclasts. Osteoclasts are being activated by many things, including hormones. What's the hormone that activates osteoclasts? Yes, parathyroid hormone. It activates the osteoclast and leads to destruction and resorption of bone to free calcium into the blood. Okay? Now we are moving to talk about malignant tumors of the bone. So what we call the malignant tumor that occur in bone or arise from bone? What is its name? We call it osteosarcoma. Why it's sarcoma? Now, you know we divide tumors into carcinomas and into sarcomas, right? Carcinomas are the tumor that occur in the epithelial covered tissue, like like the GI tract, like the skin. So we have adenocarcinoma and we have squamous carcinoma. So this is what you mean by carcinoma. It's composed of epithelial cells. But when the tumor, the malignant tumor, occur in soft tissue and bone, we call it sarcomas. So we have osteosarcomas, liposarcomas, and chondrosarcomas, etc. Now we differentiate between sarcomas according to the matrix being produced by that sarcoma. So if this sarcoma is producing osteoid, we are going to name it as osteosarcoma. If it's depositing cartilage, we are going to call it chondrosarcoma. And if it's producing adipocytes and fat inside the cells, liposarcoma, etc. So osteosarcoma is the malignant tumor of bone, and you can see it here just regarding the anatomy of the bone. We have, this is the femur, we have the epiphysis. After the epiphysis comes the metaphysis and then the diaphysis. Now, the osteosarcoma arises from the metaphysis most of the time. So it's usually arises from the metaphysis, and it usually arises in young persons, unfortunately, in young adolescents and in young adults. And it's very aggressive tumor with poor prognosis. Sometimes even with treatment, it carries a really bad prognosis. So unfortunately, it occurs at young age group. This is another picture. Now, the most common bone that's involved by osteosarcoma is usually lower femur, upper tibia. We said the part is the metaphysis, but it involves the metaphysis of a lower femur and upper tibia. That's around the knee joint, okay? So this is the most common part. If you look at, this is the knee joint, this is bended knee joint, this is here at the upper part, this is the tibia. And again, to the anatomy, we have, this is the cortex, and here this is the thick white part of the bone. We call it the cortex. And in between, we have the medulla. The medulla usually rich in fat, and of course, we have hematopoietic cells arise from the medulla. So here the cortex is intact until we have this large tumor destructing medulla, destructing cortex, the upper one and the lower one, and even it involves, it extends into where? Into the knee joint. If you look here at the lower part of femur, it's intact, cartilaginous cap at the knee joint, but here we don't see the cartilage. It's even eating the cartilage. So it's very aggressive tumor that can extend into outside the bone, into the knee joint, sometimes into the soft tissue, sometimes it may even ulcerate from the skin, okay? So it's, if it's diagnosed late, it can have very local aggressive extension in addition to metastasis. The most common site of metastasis is the lung in osteosarcoma. Now, this is the microscopic picture for osteosarcoma. Now, sarcomas, most of the time, they are pleomorphic cells. Most of the time, they are spindled in shape. So if you look here at the cells, first of all, in this picture, the first thing that should that you should notice is that the cellularity of the marrow between, or the cellularity of spaces between the bone trabeculae. So this is very highly cellular area. The second thing, the polymorphism. If you notice, this is a very large atypical Bizarre cell in the center, and the other cells are small in size, other are medium, so they are polymorphic in the nuclear size. If you look around, we will also look for mitosis, especially atypical mitotic figures, and in addition, necrosis. The presence of tumor cell necrosis helps us to tell us that this is a malignant tumor. In addition, the fact that this tumor or this cellular proliferation are infiltrating and destroying adjacent normal benign structures, this is the most helpful feature that this is a malignant tumor. When we see it, it's extending into the soft tissue, into the fat, into the cartilage, and destructing the trabeculae here between the and it's destructing bone trabeculae, benign bone trabeculae. So this is very infiltrative tumor, and it cannot be reactive. It must be malignant process. We said we call it osteosarcoma because it deposits what? Malignant osteoid material. Here in this picture, it highlights the osteoid, the malignant osteoid. Most of the time, the malignant osteoid appear as a lace-like deposits, pink in color, like you can see here, and the edges of these irregular, immature bone trabeculae, they are not like the mature in shape. They do not resemble the mature osteoid trabeculae. They are very irregular, they deposit haphazardly, they do not have any specific arrangement. In addition, when you look at the edges of these osteoid material, we have the malignant tumor cells that deposit this material. The tumor cells are hyperchromatic, pleomorphic, and abnormal in looking. Of course, some of you may say they are not that atypical, looking that much atypical to me, but actually osteosarcoma can be very well differentiated. In fact, in terms of differentiation, it's different. It can be very well differentiated and can be poorly differentiated. But actually, even the well-differentiated osteosarcoma, they have very poor prognosis. So that does not mean that it's well differentiated that this patient is going to have a better prognosis. And most of the time we have to look at the whole picture. We have to see what's the clinical picture, what's the radiological big picture, what's the radiologist think about this bone lesion. It's very important. So it's a teamwork. We don't just look at a small piece under the microscope and diagnose osteosarcoma. Not all of the time. Sometimes we have difficult cases, sometimes it's easy. Now, the second part that occurs in bone, the second malignant tumor we are going to talk about is chondrosarcoma. Now, this is a gross picture for chondrosarcoma. This is how it looks grossly. This is the tumor. It's invading the bone, and it's invading the fat. This is the yellow part here. This is all a fat, and maybe there was muscle here. And this thin part is actually the skin that's covering the ischium of the pelvis at this part. Most of the time, chondrosarcoma, how they look grossly, they look lobulated tumor. So somehow circumscribed but lobulated, a lot of lobules. And they appear grossly white to gray in color. Why white to gray? Because cartilage, or when it's deposited grossly, it looks like white to gray in color, and sometimes myxoidish in appearance. So this white appearance to gray appearance, it gives you a hint that there is a cartilage inside this tumor. And when you cut it with your knife, you will feel sometimes the cartilaginous consistency of the material in that tumor. So most of chondrosarcomas, like we see in this picture, arise from the central axial skeleton. That's the pelvis, the hip joint, the vertebral column. Of course, it can occur at the peripheral skeleton, but most of the time it's central tumor, and it can occur at any age, not like osteosarcoma, young patients. It can occur at any age, but mostly in adults. Okay, in adult age group, not in young age group. This is another gross picture. Here, if you can see the lobulation, it's matted appreciated in this tumor, the lobules of the chondrosarcoma. In addition, this gray material here, it's actually cartilage, malignant cartilage being deposited. It's eating the bone. It's obvious that this is a cartilaginous tumor. It's malignant. It's not benign. Why? Because it's destructing the bone, and it's involving the muscle. Look here, this part is actually involving a pre-existing muscle here, skeletal muscle, and this is a remnant of the muscle at the top part of the picture. This is the residual muscle. So this must be malignant just from looking at the gross picture without even looking at a microscopic picture for this tumor. There is a slight male predominance, but actually not much difference between male and female. Usually the chondrosarcomas are slowly growing tumors, unlike osteosarcomas. So they may stay there for a while before they are discovered. And also, most of the time, they become de-differentiated from a well-differentiated chondrosarcoma. So we have well-differentiated chondrosarcomas, and we have de-differentiated. It's one of the tumors that may de-differentiate. And when well-differentiated chondrosarcomas stay for a long time, they have more mutations and additional mutations with time. It will lead to de-differentiated. The aggressive part of chondrosarcoma is the de-differentiated tumor. But the well-differentiated can stay for a long time before they're discovered. This is another chondrosarcoma, but here it's in the peripheral skeletal system. Here it's in the femur. If you look at the medulla, we have white to gray deposited to bluish white cartilaginous tissue inside the medulla. It has a predilection for involvement of metaphyses or diaphyses. If you look at this here at the arrow part, it's involving the metaphyses, but here the diaphyses is also involved. The cortex is intact. It's not infiltrated by the tumor, but the cortex here at the lower part, it's become thickened. Why? Because as a reactive process, it may have thickening at that area, and we call this periosteal reaction. Now, under the microscope, the first thing you should look here at, as we have said, the cellularity of the tumor. Now, this is actually a very cellular tumor. If you know the normal histology of cartilaginous tissue, it's very hypocellular tissue most of the time. It's very hypocellular. We have chondrocytes inside the cartilaginous tissue that are evenly spaced and that are stays in empty spaces. We call them lacunae. So if you look here, it's very cellular. And we have grouping of chondrocytes. They are not evenly spaced. They are haphazardly arranged, and they are depositing this bluish, myxoidish, cartilaginous material in between. In addition, if you look carefully at the lower part of the picture, it's infiltrating between and bone trabeculae. So it's infiltrating and destructing benign tissue. That's a strong hint that this is a malignant tumor. Another picture. This is how chondroid material appears under the microscope. It's bluish in color. And we have the chondrocytes. We have grouping of chondrocytes, and we said this must be abnormal, and they are not evenly spaced, and sometimes we can see more than one nucleus inside the lacunae. So not all. This is a hint that this is a malignant tumor when you see more than one nucleus inside a chondrocyte. We don't see mitosis in this tumor because it's a well-differentiated tumor. In de-differentiated and poorly differentiated chondrosarcoma, we will see more mitosis and more atypical forms of mitosis. Now we are going to cover another bone tumor, another bone sarcoma. Now if you look carefully, please stop side talks there at the end. Okay, so if you look, this is a part of what? This is the diaphysis of the femur, okay? If you look carefully at this diaphysis, if you were asked where is the tumor? Okay, you have to know what's normal and then to know what's the abnormal. So normally we said there are cortex and medulla. If you look at the cortex at the bottom of the picture, it's intact, it's white, it's thick, it looks normal. If you look at the cortex at the upper part, it's being infiltrated by this hemorrhagic brown lesion, okay? So this actually hemorrhagic brown lesion can be benign, can be malignant, we don't know. But it's one of the most common malignant tumor that occur in the diaphysis and intracortical. The first thing you should think of is Ewing sarcoma. Ewing sarcoma, it occurs intracortical in the diaphysis, and it occurs again like osteosarcoma in children and young adults. So unfortunately, it's a sarcoma of young age group again, and there is a slight male predominance. Usually there is not that much difference between male and female ratio. And it appears grossly as brown to red due to the presence of hemorrhage inside the tumor. That's why it appears brown to red in color. And here this tumor is not infiltrating the marrow. The marrow is intact and it's yellow in color. Now, how Ewing sarcoma appears under the microscope? Ewing sarcoma is one of a famous group in pathology. We call it small round blue cells, tumors. From their name, they are small. The tumor cells are small. Unlike other tumors, usually the tumors are large cells. So they are small, they are rounded, not irregular. The nuclei are perfectly rounded, monotonous. Every tumor cell looks like her neighbors. There's no pleomorphism in these tumors, not that much appreciated. And blue in color, because mostly blue because of the high NC ratio. The nuclei, relatively to the cytoplasm, they are large, that's why they appear blue in color. And we have a group of tumors that look just like this tumor, including Ewing sarcoma. We have other tumors like, for example, rhabdosarcoma, embryonal rhabdosarcoma. It looks one of the small round blue cell tumors. And we have in the kidney Wilms tumors. Wilms tumor, another example of small round blue cell tumor. So, but being in the bone, that's a good hint that this is actually an Ewing sarcoma because it arises in the bone. The other hint here that this is Ewing sarcoma, if you look carefully at the cytoplasm, here it's clear. It's a white and clear cytoplasm. Why clear? Because these tumors have deposition of glycogen inside the cytoplasm. How we can highlight? We have actually special stain that can stain glycogen and highlight glycogen. We call it, this is in this picture, the periodic acid Schiff stain. Now, periodic acid Schiff stain, it's stain the glycogen as red in red color. So here, after the stain, they appear as reddish granules, intracytoplasmic granules, and it's a very nice stain. If you add diastase to this stain, the diastase is an enzyme that will digest the glycogen, and it will again it will look again without these granules. So the PAS stain, it will highlight the glycogen in Ewing sarcoma. Okay, so we have covered osteosarcoma, chondrosarcoma, and Ewing sarcoma. If you were asked in the exam what's the most common bone tumor, malignant tumor, what would be the answer? What? Okay. Anybody have other? It's actually, okay, if you think wider, it's actually metastasis. Okay, so metastatic tumors to the bone are more common than primary bone tumors. Okay, so but this is usually in adult age group. But mets are very, very common to the bone because the bone is a very vascularized tissue, and a lot of actually any tumor in the body would love to metastasize to the bone, and especially in adults. And so this is example and where we have the vertebra, and we can appreciate this metastatic nodule inside the vertebral column. Mets usually to the axial skeleton most of the time, the hips, the vertebrae, and the ribs. But it can also metastasize any elsewhere. It's not a rule. What are the most common tumors that metastasize to the bone? The most common tumors that are the usual tumors: breast cancer, kidney cancer, because it's very highly metastasizing. The renal cell carcinoma, they metastasize anywhere. They can even metastasize to the skin. Lung cancer, thyroid cancer, prostate cancer, and sometimes we discover the patients when they appear late in their presentation. They present with pathological fractures, and then with further workup we discover that he have, for example, prostate cancer, and he don't know. So sometimes we discover from the mets to the bone, not from the original history. And sometimes they are known. This patient is known to have breast cancer and present with a bone lesion. The first thing you should think of is mets from the breast cancer she has. So under radiology, we divide the metastatic tumors into two types: osteolytic tumors and osteoblastic tumors. Osteolytic because they are destructing the tumor cells, destructing the bone trabeculae, and under the X-ray and the radiology, they appear as lytic lesions, empty spaces inside the bone, and sometimes, rarely, they induce reactive bone formation, induce osteoblasts to produce more bone trabeculae, and we call them osteoblastic tumors. The most famous tumor of being osteoblastic is what? Prostate cancer. Prostate cancer is the most common one to cause osteoblastic bone reaction and osteoblastic mets in the bone. Now, this is an example. This is the vertebral column. It's an X-ray for a patient with prostate cancer. Now, where's the mets? I can appreciate it can be very hard for you. You need a radiologist to appreciate, to differentiate between what's normal and what's abnormal. But if you think, usually the bone appears gray under radiology. When it's very white in that area, that means there's an osteoblastic lesion. And it's when there is a lytic lesion, empty space, that means there is some lesion that's causing destruction in that area. Now, if you look carefully at this here, this vertebra in the center, there is a whitish, more white nodule. It's very white compared to what bone should be. So this is an example of osteoblastic mets to the vertebra in a patient with prostate cancer. Another example here, if you look carefully at the at the ribs. Okay, if you look here to the right of to the left of the picture, there is a whitish nodule at the rib. Maybe this is another one. So this white nodule, again, another mets from patient with prostate cancer, and it's causing osteoblastic mets to the ribs. Another example for osteolytic lesions. Here, there are numerous osteolytic lesions. If you look carefully at the ribs, there are a lot of empty rounded spaces, okay? They look black in color, more black than they should be. And this is a patient with breast cancer and multiple metastatic osteolytic lesions. And here is another patient with breast cancer and have mets to the pelvis. We said it's usually the axial skeleton that's where we have the mets most of the time. We don't usually see much breast cancer mets to the femur or to the tibia, etc., to the peripheral axial skeleton. It's most of the time to the central axial skeleton. Now, how do we see, for example, metastasis under the microscope? It just looks like the primary. For example, breast cancer, how it looks in the breast, we have the same tumor cells, just they present where? In the bone. If you look here, you have to, excuse me, هلا دخلت? No, we are too late. We are about to finish. عفوا ممكن تحكي مع المشرفة تحكي لها الاكسكيوز تبعك. Okay. So here we have nests of epithelioid cells. We have a lot of epithelial cells. They are not spindled like the sarcoma tumor cells, okay? They are not depositing osteoid or depositing cartilage. So that's why you have to think of epithelial tumor. Sometimes if it's metastasis from the colon, or mucinous tumor of the lung, you can see mucin. You can see the glands are producing that mucin, just like it's in the lung, it looks in the lung or in the colon. If it's squamous, you see the squamous material, you see the keratin. Okay, so here you have just the same epithelial nests and epithelial ducts inside the breast, just they are present inside the bone, and it's destructing the bone trabeculae. As we have said, breast usually cause osteolytic lesions. Now, after finishing talking about malignant tumors in the bone, we are going to talk about benign conditions and benign lesions, not only tumors in the bone. One of the most common benign, it's the most common incidental finding and benign lesion in the bone, we call it osteochondroma. Why osteochondroma? Because it contains of osteoid and chondroid material, so that's why we call it osteochondroma. And it has another name, we call it exostosis. Exostosis because it's a projection of the bone at the metaphysis in the of the long bone. So it's usually appears incidental finding when you do X-ray for just after accident or after just X-ray for any reason. You find it incidentally most of the time, but sometimes it may be causing pain, local pain in that patient. So the patient may seek because of there's a pain, and you do the X-ray and you see this projection from the metaphysis. Even radiology, they can tell this is exostosis. Just from there is a projection from the metaphysis in the bone like this X-ray. So this is the typical appearance for osteochondroma. However, there are relatively very rare conditions where we have syndromes and we have multiple osteochondromatosis. They have osteochondromas in every long bone. They have even sometimes in the fingers. So they can have exostosis everywhere. And in these patients, it occurs at a young age group and may cause deformity, problems in development, and very rarely they can transform into chondrosarcoma. So if they were to transform, they will transform into chondrosarcoma, not osteosarcoma. Okay, this is the gross appearance of osteochondroma. زي ما حكينا مكونة من chondroid part and osteoid part. The stalk horn of the lesion is the osteoid part, and there is a cartilaginous cap. We call it a cap because it's capping the stalk. Okay, هي اللي لونها that's look blue here at the top of the lesion. This is typically osteochondroma. You can tell grossly that this is osteochondroma even without microscopic examination of the lesion. Usually, it's benign. It's just need excision in this patient because he has symptoms like pain. Most of the time, it's just pain, and it extends, as we have said, from the metaphysis of the long bones. It can vary in shape. If you look at this osteochondroma, it's with a broad base in comparison with the previous one. And most of the time, we have to look at the cartilaginous cap thickness. We have to measure the thickness because we are afraid when it's more than 3 centimeters, we may be worried about transformation into malignant tumor. On computer 3, please stop side talks. الشاب اللي على الكمبيوتر رقم 3 سامعني؟ ممكن تغير مكانك لو سمحت؟ Please change your seat. Okay? So we have to measure the cartilaginous cap because it's rarely transformed into chondrosarcoma, not usually, okay? It's very rare. Now under the microscope, here is the chondroid part to the left and the osteoid part to the right. They are completely benign. Look at the benign cartilage. As we have said, benign cartilage, it's very hypocellular. The chondrocytes are evenly spaced. In each lacunae, we have only one nucleus. There are no pleomorphism, no mitosis, nothing. And the osteoid part to the right side of the picture, very mature osteoid trabeculae, and we have fat in between them. Only the treatment is just surgical excision because it's benign tumor. Now, when we're talking about the anatomy of the bone early in this in the lab, we have said that we have the epiphysis, metaphysis, and diaphysis. This is a lesion that occurs where in this picture? In the epiphysis. This is epiphyseal tumor, so the location is very important. The second thing, this tumor is brown in color and hemorrhagic in color and occur in the epiphysis. The first thing you have to think of is what's called giant cell tumor of bone. Giant cell tumor of bone is an epiphyseal tumor that appears grossly as brown and hemorrhagic and locally destructive tumor. Because of this local destruction of the bone, it will appear as a lytic lesion on radiology. This is in radiology, it appears as a lytic lesion, empty, more black in color at the epiphyseal part of the femur in this patient. Why do we call it giant cell tumor? Simply because under the microscope it's composed of huge, giant, multinucleated giant cells. Now, you can see a lot of giant cells in this picture, and in between the giant cells we have mononuclear cells. But the mononuclear cells, they have just the same nucleus as of the nuclei in the giant cells. They have just the same morphology. If you look here, we have a nucleus, rounded nucleus with prominent nucleolus. Again, in the giant cells, the same nuclei, the rounded nucleus with prominent nucleolus. And if you look carefully to the lower part of the picture, we have RBCs, a lot of hemorrhage. That's why it appears grossly as hemorrhagic brown mass, because of the presence of hemorrhage inside the giant cell tumor. And in old hemorrhage, they will appear as hemosiderin stain or hemosiderin pigment inside the macrophages inside these lesions. So usually they are not usually, they are benign tumors. The giant cell tumors are benign tumors, but the problem is that they are locally destructive tumors. They can expand, they can cause pain, they can cause pathological fractures in that area, and they can cause deformity. So sometimes, like in this patient, they need resection because of the local destructive nature of the lesion. But we don't use radiotherapy, we don't use chemotherapy. They are benign tumor. Just excision is the simple treatment for them. Now we are going to cover about here what we have, the brown tumor. It's actually a misnomer. It's not a tumor. It's actually benign, totally benign, reactive process in the bone, but it's we call it still brown tumor because grossly it appears as brown lesions in the bone, multiple brown, not just only one. Now, what is the most important thing is the cause of brown tumor. The cause of brown tumor, usually we see them in patients with long-standing hyperparathyroidism. As we have said, in the parathyroid hormone, it will stimulate what type of cells in the bone? The osteoclast. Excellent. So in long-standing patients, for example, with adenoma, parathyroid adenoma that's producing hormone for a very long period, they will induce the osteoclast will proliferate and will form, will destruct the bone trabeculae and will resorb bone everywhere in the body. And if you look here, this is a well-circumscribed nodule composed of osteoclasts, multinucleated giant cells. They are the osteoclasts, and they sometimes they are causing fractures here, resorption of the bone trabeculae. The bone trabeculae are fragmented and destructed because of the activity of the osteoclasts. And because of this destruction, we have hemorrhage inside the proliferating nodules of osteoclast, and this hemorrhage will, after a while, will stay as hemosiderin inside the macrophages, and that's why they have the name of brown. That's why they are brown in color. And in long-standing, that we have fibrous, even fibrous tissue proliferation, and fibrous connective tissue proliferation between the osteoclasts. This is a higher magnification. The osteoclasts are smaller in size in comparison to the giant cell tumor. And they are of variable sizes, and they are in nodules with hemorrhage and hemosiderin deposition. We don't see much of brown tumor nowadays because parathyroid adenomas are discovered and treated early, and the patient come early in their and diagnosed early and don't have a lot of bone lesions and bone manifestation. Now, another benign bone tumor we are going to cover is the osteoid osteoma. The osteoid osteomas usually occur in the tibia and femur most of the time, and we have another similar tumor that occurs in the central axial skeleton. We call it osteoblastoma. So osteoid osteoma and osteoblastoma, they are very similar. There are certain differences, the site of the lesion and the size of the lesion. Osteoblastoma are larger in size in comparison to the osteoid osteoma, are smaller. And osteoblastoma in the central axial skeleton, but osteoid osteoma in the peripheral axial skeleton. They can be discovered incidentally, or sometimes, especially osteoid osteoma, they present with pain, and patients present with localized bone pain that's relieved by aspirin. So this is the usual presentation. And sometimes just local excision, because they are benign, just surgical excision to relieve the patient from the pain, is that's the only treatment is needed in the patients. And the patients usually, they are young adults that come in the second decade of life in osteoid osteoma. This is the last slide we are going to cover. The final topic we are going to talk about is fibrous dysplasia. Now, from its name, it's fibrous. If you look at the picture, there is a lot of fibrous tissue, and we have this irregular woven bone. Actually, in the fibrous dysplasia, the woven bone are very irregular and bizarre in shape. We call them the Chinese letters. Excellent. We call them the Chinese letters. They have this bizarre, and they have other names. And in between these abnormal woven bone, immature woven bone, we have in between the fibrous material. They are usually monostotic. That means involving just one bone. But sometimes when we see polyostotic forms, we have to think about syndromes, patients with certain syndromes, when you see fibrous dysplasia involving more than just one bone. The most common famous syndrome you have to know about is the McCune-Albright syndrome. This is actually, in McCune-Albright syndrome, they have bone manifestations of fibrous dysplasia, they have endocrine abnormalities, and they have skin manifestations as cafe au lait spots. The problem with fibrous dysplasia, it's a benign condition, it's not malignant, but the problem that it can cause, especially in polyostotic conditions, it can cause bone weakness, fractures, deformities, and developmental abnormalities. Okay, so but most of the time when it's solitary, it can cause just localized weakness in just one bone, and sometimes fracture in that bone. Okay. Usually the age group of involvement is in adolescents, and when in the syndromatic patients, they come in young children, in children age group. So usually bone lesions are very common, either benign or malignant, in young age group. Okay. Any question? Thank you.